Okay, we're going to go over the second part of Chapter 8 here. This will focus on incisional glaucoma surgeries. Incisional glaucoma surgeries can basically be thought of as either penetrating or non-penetrating procedures. Penetrating could be trabeculectomy, full-thickness procedures, full-thickness sclerotomy, phaco trabeculectomy, and the non-penetrating procedures could be visceral canalostomy, non-penetrating deep sclerectomy, or canaloplasties. And again, this is for filtering procedures, okay, incisional filtering procedures. There are a number of other glaucoma surgeries, pediatric procedures such as goniotomy and trabeculotomy. Then you have your tube shunt procedures like your Ahmed or Krupin, which are valve setons, and your Barvel's Molteno and others, which are your non-valve setons. Let's first go over trabeculectomy. This is probably the most commonly performed glaucoma surgery. It's done for suboptimal IOP control on someone who's basically failed maximal medical therapy and already usually undergone laser trabeculoplasty. Progressive visual field loss is the most common indication, although you can also do it for progressive optic nerve changes or when a patient's not in the ideal target pressure range. Maximal tolerated medical therapy is a term that's been used for a while. It's determined by advancing the medications and documenting any intolerances that occur or failures of therapy. And it may take a little bit of time to really determine what that is for each individual patient. It does not mean that every patient's on every medication. It's basically a maximal medical regimen for each individual. For that reason, they've come up with this new therapy, which they call core therapy, which is basically therapy based on a combination of medications likely to work well together, and if it's not appropriate, you move on to more aggressive interventions. But basically, patients will wind up on a combination of typically 3 or 4 IOP lowering medications, and if they fail those, you could call it failed therapy, either with maximal tolerated medical therapy or failed core therapy. Trabeculectomy is a procedure, as mentioned, which we'll show in a few minutes. Contraindications would basically be a blind eye, active rubiosis or iritis, or very thin sclera or scarred conjunctiva, which isn't likely to allow for filtering blood to form. Relative contraindications include younger age, aphakic or pseudophakic patients, patients with prior failed trabeculectomy, and consider contact lens wear as relative contraindications if they still wish to wear contacts afterwards. Preoperative evaluation is basically similar to all your other things. You do the full exam and history. You typically want to discontinue any anticholinesterase or indirect cholinergic agents 2 to 3 weeks before to prevent any postoperative inflammation. And you want to ideally normalize your IOP as much as possible preoperatively to prevent or lower the risk of any postoperative complications. Ideally, your patient should be taken off of aspirin or other blood thinning medications, and you want the patient's blood pressure to be controlled as much as possible. Again, to reduce postoperative and intraoperative risks or complications. Trabeculectomy can typically be done either through a fornix-based or limbal-based approach that just describes where you make your conjunctival incision. In fornix-based approaches, you're basically doing a peritomy. In a limbal-based approach, you make your incision about 10 millimeters closer to the limbus and dissect it forwards. Typically, I like the limbal-based approach, and I'll describe why later. In trabeculectomy, we commonly will use adjunctive medications called mitomycin or 5-FU. These are basically antifibrotic agents. They improve the outcome of filtering surgery and allow for better long-term IOP control. However, there is an increased complication rate with these medications, so you have to use them with care, especially in primary filters or young myopic individuals where there's a higher rate of hypotony. Here we have 5-FU. This is not commonly used intraoperatively anymore, although it's how things started. It's basically a pyrimidine analog, and it works by inhibiting fibroblast proliferation to reduce scarring, and it does this by undergoing intracellular conversion to active FDUMP, which interferes with DNA synthesis by inhibiting thymidylate synthetase. You basically can apply 5FU intraoperatively on sponges at a concentration of 50 milligrams per ml. But again, we typically use mitomycin intraoperatively now, partly because there's a longer half-life. Postoperatively, 5FU can be very useful as an adjunct to help scarring when you still see that occurring despite mitomycin. And you can give it postoperatively in the clinic at a 5 milligram dose in the 0.1 cc volume. And you can titrate the total dose to the healing response that's seen. But it may cause some corneal toxicity. Mitomycin C, is shown here in the imaging, is an alkylating agent, and it works again to inhibit fibrosis from occurring. In this case, it's working as an alkylating agent that cross-links DNA, so again the fibroblasts cannot really proliferate well. It's usually given at concentrations of 0.2 to 0.5 milligrams per ml, with a duration of anywhere from 1 to 5 minutes, depending on surgeon preference. Here at Stony Brook, mitomycin is supplied at a standard concentration of 0.4 milligrams per ml. For my surgical procedures, I will typically dilute this down to 0.35 milligrams per ml. And again, that's just because it's left over from my own personal training, and it is a concentration that has seemed to work well for me without complications. Okay. After you've done your trabeculectomy flap, you have to close it. There are different techniques described to close the flap to prevent postoperative hypopotony. One can use releasable flap sutures, which we will learn to do in the wet lab. Otherwise, what's commonly done is you just place 10-0 nylon sutures, and if they need to be cut later on, you can lyse them at the argon laser using a Hoskins suture lysis lens, as shown in the image below. Again, these are courtesy of Dr. Allwood. Typically, suture lysis is done with best effect in the first 2 weeks, though you will sometimes be able to do it even significantly longer or later if you used anti-metabolites.